All right.
Hi, I'm Jennifer Novak, the chairperson of the NSCA's Sports Medicine and Rehabilitation Special Interest Group. And in a way to acknowledge that March is National TBI Awareness Month, I wanted to do an interview with a professional I know who has been working with people suffering from concussions and other types of traumatic brain injury for a long time, and that's Dr. Ben Behrendt. He works in brain and body rehabilitation specialists, which happens to be the clinic that I get a chance to work in. So I know him well, but I wanted to kind of get his background and share some of the cool things that he does to help people recover from those types of injuries. So Ben, I know you have a very personal experience with a traumatic brain injury yourself, so I'd love for you to share for a minute about that and how it sparked your interest in studying neurological rehab.
Good morning, Jen. Glad to be on this video chat and interview with you. Yeah, I was in a coma when I was 10. I almost died. So I was in a skiing accident, went over a mountain of snow, landed 40 feet away in my head, and was in a coma for 5 days. So it really, that experience and going through that, it sparked my interest in brain injury, having to recover from that when I was 10. So I had to relearn everything over from age 10, how to walk, button a button, tie a shoe. When my birthday was quite a bit. Wow. So that really sparked kind of my journey and a lifelong learning in traumatic brain injury.
That's amazing. I can't imagine how your family felt wondering whether or not you were going to survive that.
Yeah, they actually had some people lined up from our organs, so it was questionable.
Oh my goodness. Well, you have studied and you practice in a form of neurology that's called functional neurology. When people ask me about it, I say that it's the neurological version of functional medicine, where doctors go in and they try to find the root cause and the pathway of what's causing the symptoms or the illness that the person is having, and try to rebuild from there. And I feel like functional neurology is maybe the same thing for the brain after an injury or insult. Would that be accurate? And do you want to discuss how that works with concussion rehab?
Yeah, for sure. Now, functional neurology, as you said, it's kind of as functional medicine, a laser approach or a directed approach to say also into the exercise world, a way to exercise the brain and pathways in the brain that are not working so well or overworking, and then making the brain and brainstem pathways work better and more efficiently. So in terms of the sports world, looking at say a soccer team, you have all the players on the field, one gets injured, and then you have you can sort of play the game, all right, then you get more people injured, and all of a sudden you start having trouble playing the game. And that's where a traumatic brain injury happens, is you get some injured players on the sideline or not working so well, and we work on getting those ones better with a laser approach to getting the brain pathways better. And that would be understanding the functional neuroscience between brainstem and the neurological pathways.
That is very cool. So let's just say that someone is diagnosed with the concussion and they have all the symptoms that people recognize of the sleep disturbances and headaches and nausea, vomiting, trouble concentrating, all of that stuff. How do you evaluate someone? What are you looking for? You see the symptoms already, so what are you looking for to determine how you approach that athlete?
Yeah, for sure. That's when you have all those symptoms, you got to really look at where it's originating from. So looking at if they have nausea or dizziness, is it a vestibular concern? So evaluating the vestibular system. Is it an ocular system, which also can play a role into connection with the vestibular system? Is it they have light sensitivity, sound sensitivity? Are we looking at the brainstem area, in the upper part of brainstem? Is it a concept that they just don't feel well? Fogginess. Fogginess can also be a visual thing where they have instability in their eyes, and that's where we want to look at the ocular system again and what's causing that fogginess or visual changes. And you have headaches. Where is that being generated from? Cortex, brainstem, mechanical. And so we want to take a look at all those areas and the whole system and see which pathway, which area is not working down, what's breaking down, and then what area is going to help improve that, or what modality. Is that an eye movement? Is that going to be a vestibular input? Is that going to be a somatosensory or a joint movement? Is going to be kind of a top-down brain approach or a bottom-up somatosensory approach, kind of like combining all those areas together and seeing what is going to be work best for that person. So it's an individual approach because each head injury is very individual.
I find that absolutely fascinating, because I think in the general rehabilitation world, we do think of the somatosensory and the proprioceptive and working from a bottom-up approach. And certainly it's been effective, but I just find it fascinating. It sounds like you're talking about a more interdependent and all-inclusive mapping system. So can you break down what a functional neurologist considers the different aspects of that mapping system?
Yeah, so we can all like organize pretty much the body into mapping systems. If those maps get skewed or altered from a head injury, then we have to look at those mapping areas. And what are the greatest mapping areas? It really comes down to our vestibular system and its connections in brain that tell us where we are in space and where space is around us. The vestibular system is the only organ in the body that has a solid central point that doesn't move. Pretty much everything else can move. So it gives us a ground or a basis of movement itself, and ability to adjust muscles, adjust eye movements, adjust posture to govern what's going on. And if those maps get skewed, then your postural stance changes, your gait changes, your ability to lift something changes, and then it's where you start getting more into the injury from sports as well. And we also have we call retinal topic or ocular mapping areas, which kind of got the same thing that also overlaps into the vestibular system. We have sound mapping areas. That both of those live in the upper part of brainstem. And we also have like somatosensory areas in the brain that have mapping as well in the like parietal and sensory cortex there.
Wow, that's truly, truly amazing. So we really are an interdependent dynamic system that you have to address every system to just make that body as whole as possible, is what I'm hearing from you. That's very cool. So let me ask you, does traditional imaging like MRIs and CAT scan, will that detect some of these deeper areas that, or do you have to rely on your evaluation?
Oftentimes you're not going to see much on a CT or MRI. Most likely not.
You'll see a bleed, right? But you won't.
If there's frank pathology or damage, you probably see it. You get more specific into like a DTI, a diffuse tensor imaging, and some other ones, but most of the time you don't see them on those imaging unless you get into the tractography of imaging. So in order to look at it, you have to look at it a functional approach, and you have to understand, are there eye movements that are causing what's going on? So you have to understand eye movements and its correlation to brain, understanding the vestibular system coordination to walking and gait, understand it in terms of how is that going to change each of those different areas that we had talked about. And you can also use the ocular system, such as like we use right eye as a technology, and we also use posturography that give us information, just ability to stand upright and what the vestibular system is changing in that postural stance, as well as a functional exam to see the intricacy of neurology as well.
Yeah, I try to explain to people that changes in your ocular and your vestibular system can even change base muscle tone and perhaps even make you more vulnerable to a musculoskeletal injury if those aren't properly rehabilitated. So you talked about right eye and you talked about posturography. Posturography. What other tools do you have that you use as part of your rehab?
Well, in terms of rehab, we really play a heavy role on the vestibular system. So we really look at that aspect and whatever is going to kind of change us. We might do some recalibration of the central nuclei through vestibular work, vestibular ocular work, and then there's a whole bunch of other modalities that we can use with stimulation, with radio frequency, electromagnetic aspects, electromagnetic induction, some shock wave, sound wave therapy, and something that you're very familiar with, photobiomodulation, which we'd like to learn some more as well. And you're quite knowledgeable in that area as well.
Oh, well, thanks for the compliment. I love watching you work and I love working with you to support what you do. I want to ask about how you judge, some of these people can be very, very sensitive. It might depend on how many previous concussions they've had. It might be that they have other reasons for being systemically inflamed. So do you look at more reflexogenic stuff first, or do you look at the volitional movement and eye movements and vestibular, just doing typical balance, look at them on an RX pad, or do you look at the reflexive stuff, or is it a combination of both?
A combination of both. We look at, of course, reflexogenics. We can see in the autonomic nervous system with the eyes and how the blood flow is. We can also look at volitional and see how the brain integrity is. Can it actually withstand therapeutic applications? Does it have enough brain power there to volitionally move and volitionally get what you want done?
And that's that metabolic threshold that you talk about. So
Yep.
What are you using to determine? I know you keep a keen eye on these folks to see if you're starting to, push the envelope with reaching that threshold. So how do you determine that?
I mentioned a little bit on autonomic nervous system. So we might look at how the pupil dilation is. We might look at pulse oximetry, and a breakdown in movements, like cortical spinal pathways, finger tap, or other aspects that are very salient to that person that can say, okay, now we're starting to get metabolic fatigue.
I gotcha. And then do you just call it quits for the whole day, or do you let them rest and have something to drink, something to eat, or is it just, it's probably individual? I know you're going to say it's individual.
Yeah. Right. Yeah, it really comes on the person, like you're saying. Let them rest. If they can recover, we'll look at those same functionalities and see, are they returning to ability or metabolic aspect to do more therapy or play. Then let's try some more. And if they break down again, maybe we'll call it a quit for today. And that's as much as we can do.
Right. So you mentioned dysautonomia, and just for the viewers, my understanding of dysautonomia is that inability, it's a low sympathovagal tone, or the inability to toggle between understanding that your body is under stress or it's not under stress and can relax and start to repair and regenerate and digest food and all of that. And I'm pretty sure that the gut is involved with that aspect of dysautonomia. Do you want to spend a minute or two talking about that?
Yeah, it's quite amazing. They've had some research within the first 24 hours, you start seeing gastrointestinal or GI changes in the microbiome. And so that inflammation can also cause some, like, even up to the point where you have some leaky gut if it's not addressed or fixed. And of course, you have leaky gut, then you start looking at brain barrier integrity as well as that leaking. And then you have more inflammatory between gut and brain as well. And so the autonomic nervous system. Of course, you got the vagus, it always goes on to into the GI system, but that autonomic nervous system is quite strong in the GI. So you see autonomic dysreflexia or autonomic control that's not working well. You can see it in the brain and the gut as well.
Gotcha. So you combine working on restoring gut integrity at the same time that you're doing the rehab on the brain?
For sure, for sure.
Okay, okay, that's awesome. So are you working with people as early as the day after a concussion, or how soon after an injury or insult are you seeing people?
Usually we see after a couple days with a person, but the sooner the better. We can take an evaluation of them and see where they're at with their ocular movements, with their posturography. We might not do much of a treatment, but we can see where they're at and then test them again if they're not metabolically stable at that point. Then we can look at doing some therapy after that. So usually people recover from a mild injury, but if they don't have it looked at, then it can have a stacked aspect where they have injury on top of injury. And usually within the first 7 to 10 days, we definitely want to make sure that if they're not recovered, take a look at.
So are you, when you provide your rehabilitative exercises or interventions, if there's something like eye movements or complex movements of the limbs, or maybe some vestibular stimulation, are you working with the athletic trainers? Are you working as a team approach to try to give this person the best possible recovery options so that they don't have that that propensity to be re-injured?
It's always
a second injury.
Yeah, it's always best to have a team approach to make sure that these athletes are staying in the game, and of course kids and stuff, if they're make sure they're staying in school and progressing with that as well. So working with a team, athletic trainer, physical therapist, or anybody else that's on their team to make sure that things are still moving forward for that person and they're able to get back to the game as quick as possible, recover as quick as possible, and make sure everybody's on the same page.
Cool. Well, I loved hearing some of this from you. I was going to throw you a curveball question, but I'm going to back off from that because I don't want to surprise you, but we could always do a part 2, right? I just wondered if you had any closing thoughts or comments, or hopefully when I post this in the Facebook group, some people will have some questions to ask, and I can certainly forward them to you and maybe even record your answer. So any closing thoughts or ideas?
That'd be great to have a follow-up, and for sure. And my thoughts as well is to learn more on that photobiomodulation that you're quite familiar with, and we use you use as well as myself in concussion. So that'd be a great further discussion. So hopefully we can do that. In terms of if you have questions, reach out. You can get brain and body rehabilitation specialist, Dr. Behrendt. We're here to help if you've had a head injury, and we have a pretty dynamic team that we can work with. And so Jen and I work really well together. So it's great to have that aspect. So it's good to have her on our team. Yeah. So if you have questions, reach out.
Well, thank you so much. I so appreciate your time this morning. I know we both have to get on with our day. So maybe there will be a part 2. And Dr. Ben, you're awesome. Thanks so much.
I love it.
Have a great day.
Thank you. Talk soon.
Okay, bye.